So I just wanted to talk today about endocrine gets referred a lot of kind of non-specific symptoms, and a lot of the times they're not really endocrine related, but I wanted to kind of give an overview of the things that we do to help diagnose or rule out endocrine things. And the symptoms that I focused on were fatigue, excessive sweating, weight gain, and hair loss. I'll start with fatigue. There are some definitions I wanted to throw out there. So there's a lot of ways that people can be describing fatigue when they come to you and they say, I'm really tired all the time. So they either like feel really weak all the time, or they feel like they tire easily, or like mental fatigue or mental fog, or they feel like they need to sleep all the time, that kind of thing. And timeline wise, chronic fatigue is described as 6 months or more. Less than that is either subacute or acute. Acute fatigue, usually there's something you can pinpoint, like a stressor, death of a loved one, a divorce, flu, whatever. It usually doesn't require any evaluation. But subacute and chronic fatigue is a thing that a lot of physicians, their patients come to them and they say, I'm really tired all the time. And the differential is so broad. And there's really some important things that we want to ask when people bring these up. And a lot of it is related to lifestyle influences. So you want to ask about their sleep. Do they have like snoring? Are they falling asleep at the wheel? Thinking like sleep apnea? What are their life stressors? Are they having money problems or family problems, stressed at work, that kind of stuff? Poor diet, not exercising, all that kind of stuff. Up to Date has a really nice table that has a bunch of causes of fatigue kind of broken down by symptoms. So I wanted to include this just to show like how many things can be fatigue and seem completely unrelated to what they're talking about. So one thing you want to focus on is you want to take a really good review of systems when you have this complaint. Are they having things that are suggestive of lung problems, sleep apnea, heart failure? Next one. These are the endocrine and renal, they kind of lump them together. So really the only endocrine things that we think of are adrenal insufficiency, hypercalcemia, and thyroid diseases. We all know cancer, anemia, that kind of stuff can cause people to feel exhausted. Infections, always want to take a good history with that, any type of exposures or IV drug use or anything like that. Rheumatologic stuff, they see a lot of fibromyalgia or PMR. And then psychological things, including depression. I've had a lot of patients who have depression and don't know that it can make you tired. So that's something to always want to keep in mind and screen them for that. And then medications, and that includes substance stuff like alcohol, opiates, benzos, that kind of thing. So basically the endocrine workup that we do when we get sent someone that is saying they're fatigued are we do a TSH with or without a free T4 to evaluate for hypo or hyperthyroidism. And then I'll do an 8 a.m. cortisol to look for adrenal insufficiency. And there's a specific reason why it has to be done at 8 in the morning. And that's because our cortisol is naturally highest at 8 in the morning and lowest around midnight, unless you're working night shift. So if you are testing for low cortisol, you want to draw the lab at 8 in the morning because you want to see what is their cortisol doing when it should be at its highest. And then if it's low or kind of like borderline, like 7, maybe 8, something like that, then we'll do an ACTH stimulation test if we have a higher suspicion. And that's just where it's a 1-hour test. We draw their cortisol at baseline, and then we give them ACTH, which is the pituitary pituitary hormone that tells the adrenals to make cortisol. And then we draw the cortisol at 30 minutes and 60 minutes after the concentropin. And we want to see that the adrenals respond appropriately to that. And if they do, then we can say, that's great. We've ruled this out. We don't have to give you steroids. And then some other evaluation. Some of these are not really like specific to endocrine, but you know, you get a CMP, which is a calcium with albumin level to evaluate for hypercalcemia. You can do an A1C if they're having certain symptoms like polyuria, polydipsia, where you're worried they might have diabetes. And then like regular stuff, iron panel and CBC. We do a lot of celiac screens here. We catch a lot of celiac. A lot of people can, if they have like Hashimoto's or other autoimmune diseases, autoimmune diseases can run together. So that's something to do. Ours is just a reflex order. It's just called celiac screen, but it's tissue. It's the TTG antibody and the gliadin antibodies. And then celiac can lead to like vitamin and mineral deficiencies, but so can any like bad diarrhea, gastric bypass, that kind of stuff. And so we do vitamin D and B12 to rule out deficiencies, because those can also make people feel really tired. And then if all of those are negative, then we just tell them, you know, we've crossed off a bunch of stuff, of endocrine stuff, and then we just got to keep looking. Moving on to excessive sweating. So there's a lot of different things that can encompass excessive sweating. So generalized hyperhidrosis, where they feel like they're just like sweating all the time or related to certain other symptoms. And it can be because of something else or just sweating, idiopathic. And then there's some people that say, no, they just sweat at night. Sometimes it can be just the room's overheated or they have too many coverings or that kind of thing. But you do get worried if they're saying they're like drenching their clothes or they're having to change their bed sheets, that kind of stuff. Hot flashes, sometimes it's hard to distinguish those from night sweats, but sometimes they'll describe this like heat sensation in their body that's kind of rising and it's warm. They feel warm. It lasts a couple minutes and then they sweat after that. And then flushing gets more like, you'll see it like in the face, sometimes like a little, like the stomach or the trunk area, where their face kind of turns reddish or pinkish. So with excessive sweating, you want to take a good history. You want to find out the characteristics of it. Is it associated with worrisome things like infection or cancer, things like fevers, chills, weight loss, unintentional weight loss, risk factors for other infections like TB, HIV. Do they have risk factors for bacterial infections like IV drug use, recent dental work, immunosuppressed, COVID? And then hormone status, are they postmenopausal or are they on androgen deprivation therapy? Like with prostate cancer, they purposely drive their testosterone really low. And then you want to think about other endocrine symptoms like flushing, diarrhea, wheezing, heart palpitations, headaches. And you always want to think about medications. So there are a lot of medications that can cause sweatings. The main ones that we see are like SSRIs, SNRIs, and TCAs. And then, you know, if you get hypoglycemic, you can have sweating. So insulin or sulfonylureas, that kind of stuff. And this is just another table that talks about different causes of sweating, and it kind of talks about suggestive features and physical exam, and this is malignancy and infections. And then there's medications, neurologic causes like spinal cord injury, that kind of stuff. And endocrine causes. So this is where we look into excessive sweating is a little bit more of an in-depth workup in endocrine world. So the stuff that we do, we'll get a TSH and a free T4 to look for hyperthyroidism, and then plasma-free metanephrines, that'll help us rule out FeO. And so the FeO kind of triad is sweating, palpitations, and headaches. And then most people with PHOs do have really bad hypertension as well, but some people have silent PHOs where they maybe don't have that many symptoms, or they just have one of the symptoms. We get an IGF-1 to look for acromegaly. And that's usually associated with some other types of symptoms as well. Like they might complain that their ring size is like their ring doesn't fit on their hands anymore, their hat doesn't fit anymore, or their jaw seems like misaligned, their teeth are kind of changing structure. And so there's a lot of different stuff that goes with acromegaly, but we test for it. And then if they are female and they're having absent or irregular periods, you can get an FSH to look for menopause. If they say that they're getting flushed and they're having diarrhea, then you want to think about carcinoid syndrome. And the test for that is a 24-hour urine 5-HIAA. So they haven't really found that testing a serum serotonin is super helpful. So it's a 24-hour urine, and that's one of the metabolites. And then if that workup is negative, we give them a glucometer. And if they have a blood pressure cuff at home, we tell them test your blood pressure and test your blood sugar when these symptoms are occurring to see, like, are they having like hypoglycemia or hypotension that we need to be concerned about. And the stars I put beside the PHO testing and the carcinoid is that there's a lot of medications that can make these look falsely high. A lot of times we get patients that come to us with sweating and they're like on an SNRI or a TCA, for example, for depression or anxiety. And someone will measure epinephrines and the norepinephrines will be high, but that's on purpose because that's how these medicines work. So selective norepinephrine reuptake inhibitor, SNRI. So they're purposely decreasing the amount of norepinephrine. They're making more in the bloodstream pretty much. So if you measure it, which is what methamphetamines and catecholamines are, then you're just measuring the medicine. So sometimes we just have to kind of wean them off those kind of medicines and see if their symptoms improve or switch to a different class of antidepressant or that kind of thing. And then for the carcinoid syndrome, there's a lot of different foods and stuff that they have to avoid before we can do the testing because it can be falsely elevated. Weight gain. This one I wanted to include some statistics. As physicians, we're not delusional. We know that most weight gain is that people are not, knowing how much they eat and overestimating how much they burn off. But there are some things that can make it definitely harder to lose weight. So some statistics, genetics contributes 40 to 70% in most people. And so if someone has one biological parent that is obese, then their risk of obesity is 3 to 4 times higher. But if both of your parents have obesity, then you're over 10-fold risk of becoming obese yourself. And then there's multiple other factors that contribute to weight gain, including financial status, physical activity, the food environment, like can you afford to buy fruits and vegetables, or are you, a college student, you're just eating ramen noodles all the time, that kind of thing. And then adults just naturally tend to gain weight between the ages of 20 to 65. And then it kind of plateaus a little bit, and then they start to lose weight when they get more elderly. And so they did a study of over 4,000 people that were normal weight. And within 4 years, all they did was just watch these people. And within 4 years, about 5 to 9% of them developed obesity. Within 30 years, over 50% were overweight. And then 30% of females and 25% of males developed obesity. And between in the adult ages, typical adult consumes over 17,000 pounds of food, but they only gain about 1 to 2 pounds a year. And so they're thinking that you just need 100 extra calories a day to gain weight. So even just 100 extra calories a day for a long time makes you gain weight. And then there's been multiple studies that show that people constantly underestimate their calorie intake. Either they don't realize, like, they're grabbing a handful of M&Ms here and there, or they're grabbing some chips, and they just don't remember those kind of things when they're logging calories, or they think that it has less calories than it actually does. Or they go to the gym and they think, oh, I've burned like 600 calories, but it's all maybe like 300 or something like that. So recall is a big problem. Physical activity. So they did a study where they monitored people in the Amish population where they don't have high rates of obesity at all. And they noted that they take about 14,000 to 18,000 steps a day, compared to just the average American takes about 5,000 to 6,000. And a lot of that is our work dynamic has shifted. So in the 60s, about half of people were at least moderately active on their job, very manual labor type of stuff. But now over 70% of us have either just completely sedentary, like office type of jobs, or light physical workload. And so that represents a decline in us burning off about 140 calories a day in males and about 120 in females. And then the NHANES data from early 2000s, it showed that obesity was pretty strongly and inversely related to moderate physical activity, and then positively related to, TV or sedentary time, which we kind of know. But even like small differences, like even 5 to 10 minutes a day of moderate physical activity were associated with huge differences in weight. Sleep is something that we don't often think about when it comes to weight, but there's a really strong association with development of obesity, type 2 diabetes, and metabolic syndrome. With if you sleep less, if you go to sleep later, if you work night shift, it's thought that lack of sleep is associated with activation of the food reward brain regions. And so that makes people kind of seek out high fat foods. So that's like, if you ever notice a lot of people saying, oh, like I really don't eat during the day and then I binge at night, that's kind of like how it is. And then lack of sleep decreases our satiety hormones, like our incretins, and then it increases our appetite stimulating hormone, which is called ghrelin. And there are a lot of medications that are associated with weight gain, a lot of the psych drugs. And then I like this table from Up to Date because on the far right, it kind of gives you some suggestions. I think it's an old table though, because for the endocrine agents, the only thing they have listed to help you with weight in terms of diabetes for the GLPs are exenatide and liraglutide, which are Byetta and Bydureon and Victoza, but we know we all have semaglutide now, and Ozempic and Mounjaro, which is the new one called tirzepatide, which is a GLP-GIP agonist. So there are some options definitely to help with weight loss in diabetes world. So the endocrine workup for weight gain, it's not a whole lot of stuff. So we get a TSH. Hypothyroidism, it can make you gain some weight, but it's not going to make you gain like a ton, like maybe 20 pounds, if that. Cushing's syndrome definitely associated. You want to think about this if it's associated with rapid weight gain, osteoporosis, development of diabetes, hypertension, like kind of central adiposity, like their belly's getting bigger and they're getting these big purple stretch marks forming on the bellies, or a fat pad on the back of their neck. So the way that we screen for Cushing's, so Cushing's is just excess cortisol. So remember, we said that our cortisol is naturally highest at 8 a.m. and lowest at midnight. So one of the ways that we can screen for it is midnight salivary cortisol, which is a cheek swab test that they do at midnight, and they do it on 2 separate nights, and then they return the cheek swab kit to the lab. Or you can do a 24-hour urine cortisol, which is helpful for like if someone is on night shift or something where their hours are off. So it's just 24 hours. So it doesn't matter what their kind of shift is. And it's pretty much they just pee in a jug for 24 hours. Or you can do something called a dexamethasone suppression test. So in Cushing's, if you give a steroid, then their cortisol won't suppress. Like if you just give a steroid to any normal person, it will suppress them. So you give 1 milligram dexamethasone at 11 p.m. and then you have them go to the lab at 8 in the morning, and then they get their cortisol level drawn. And if their BMI is over 30, I usually do 2 milligrams dexamethasone to make sure that, they're absorbing it and everything. And then an IGF-1 to screen for growth hormone deficiency if they have certain features. The last one I wanted to talk about was hair loss. So the vast majority of hair loss it's more of a dermatology problem rather than an endocrine, but we do get this quite a bit. So I wanted to touch on it. So telogen effluvium is a very common cause of diffuse hair loss, and it basically means like stress-related hair loss. We've seen a ton of this just in COVID. Like there's like a New York Times article. It pretty much said like the year that everyone lost their hair, I think is the way that it was called. And so telogen effluvium can be acute or chronic, and it's basically an abrupt shift of hair follicles from what's called the anagen to the telogen phase. And it can be induced by a ton of stuff. Like if you ever see like someone postpartum, they're losing their hair here. Like I'm still like growing back my hair from having a baby last year. And then like major stressors, illness, surgery, any like significant weight loss or like anorexia, or just losing weight, a lot of weight in general, certain medications, iron deficiency, thyroid diseases, and then heavy metal stuff if the history fits that. These are kind of the medications that we think about with hair loss. With hormones, it just says hormones, but I think they're talking about like testosterone or something like that. So our endocrine workup is so basically thyroid disease, which we for most non-specific stuff. And then if they're female, we evaluate for hyperandrogenism, like especially if they're having signs of hirsutism, like excess facial hair, body hair. And the androgens that we look for are testosterone, DHEAS. Sometimes we'll do androstenedione, which is another adrenal androgen. If they're having certain signs and symptoms of Cushing's, we'll screen them with one of those 3 tests I was talking about. And not endocrine, but I also get an iron panel and a CBC to rule out anemia and iron deficiency. I think that's the last slide. Any questions?
Thank you so very much. That was a great presentation, and you're just like very natural flow and chill and voice. So when it comes to testing, you mentioned that you sometimes say not to eat certain foods. Does that go the same for supplements when someone's coming in, like vitamin D and B? Like, do you tell patients to stop taking them?
Usually they're fine. The one that affects the thyroid, there's a lot of stuff that it can affect thyroid labs, but the one that affects the most is something called biotin, and it's a hair, skin, nails vitamin. It's in a ton of hair, skin, nails vitamins. And so it doesn't actually mess with the thyroid, but it can make the lab look abnormal. So we'll have them hold their vitamin 3 to 5 days before we get the thyroid testing. And so that way we know if it's abnormal, then it's a true abnormal lab and it's not just from the vitamins.
That's really interesting and good to know. I know some people are sensitive, but I have a lot of friends that take biotin for their hair. I just try to like use like nail polishes instead because I'm scared to take it.
It's okay to take it. It really doesn't hurt anything. I just have them hold it before we get lab testing.
Yeah, absolutely. And with thyroid, why is it that a lot of times not a full thyroid panel is ran? Like, why isn't reverse T3 or TPO antibodies typically looked at?
So,
fine.
Sorry. Yeah, so TSH is the pituitary hormone that tells the thyroid to make thyroid hormones, which are T4 and T3. The pituitary is extremely sensitive to what's going on in the body because it's kind of our hormone control center. It tells the adrenal glands to make cortisol. It tells the ovaries to make estrogen. It tells the testicles to make testosterone. So it's kind of our control center. So if the thyroid is acting up and not making enough thyroid or making too much, then the pituitary senses that. and it'll decrease or increase its TSH. So that's why the TSH is super sensitive. It's a very good marker. There are times when you do want to test the TSH, the free T4 and the free T3, and mostly that's for hyperthyroidism, because the TSH in usual hyperthyroidism, like from a thyroid problem, is suppressed because it sees all this thyroid floating around in the system, so it shuts down the signal. And then the T4 and T3 you want to test because some people can just have one elevated and not the other. And that helps you kind of figure out the cause, because sometimes it's something that you have to treat with medicine. Sometimes it's something called thyroiditis that you don't need to treat at all. It just resolves by itself. So that kind of thing. And then antibody testing, so TPO antibodies, we check those for hypothyroidism a lot. And that's to look for autoimmune hypothyroidism, which is called Hashimoto's disease. And the antibodies themselves don't cause symptoms, but they eat away at the thyroid over time and increase the risk that someone's going to develop hypothyroidism or underactive thyroid. And then when they develop hypothyroidism, that's usually when they start getting symptoms. And you don't treat the antibodies, you treat the thyroid level itself.
Thanks. Thank you so much.
Oh, you're welcome. Reverse T3. So reverse T3 is we kind of call it like the garbage dumpster of the thyroid. So whenever we get sick, super sick, something called sick euthyroid can happen. And this is like ICU, like kind of illness, where the thyroid kind of, to try and cool down the body, it'll decrease the thyroid hormones on purpose. And what it does is it shifts the T3 to reverse T3 because it's an inactive hormone. And so measuring reverse T3 can help us see, is this sick euthyroid where you don't need to treat it, you just watch it over time and it'll get better when the person gets better? Or is this something where the pituitary is not sending the signal to the thyroid? Because whenever you check the labs, it'll look like the TSH, the T4, and the T3 are all low. So that's the only reason to ever check it, is kind of in the hospital. And it takes like 2 weeks to come back. So it's not a super helpful lab, but we don't base medicine on it and it doesn't change anything. So whenever my patients ask for that, I pretty much just tell them it's a waste of money lab. Like I would hate to waste their money on something that I know doesn't mean anything in terms of their treatment.
Thank you. And I'm sure that that's really helpful, especially like to many people out there, because there's just so many things we read too, and medically, like, why am I not getting all the tests? That's helpful. Does anybody else have any questions? Janet, Dr. G, or Mitra? Or comments? It's fine too.
That's a good overview. Thank you so much. I
Oh,
liked it. It reminded me of my years in endocrinology, doing things other than diabetes.
All right. Well, thank you guys.
Thank you. I just have one announcement. Our next one's going to be July 13th with Jessica Perini. Dr. Perini is going to be discussing osteoporosis. So hope you guys can join us. And if you need anything else, please reach out at any time.
Thank you.
Bye.